All right, let's call this meeting to order. Agenda item number 1 is approval of the minutes. Included in your packets are copies of the minutes from the May 15th public meeting of the Commission. If there are no changes or corrections, I'll entertain a motion for approval. Second. Discussion? All in favor? Aye. Any opposed? Okay. Thank you, Dr. Barr. Minutes are approved. I'd like to make a couple brief comments. Commissioner Conway will complete his service with the MHCC today. Reverend Conway has the notable distinction of being appointed by Governor Ehrlich in 2005 and being reappointed by Governor O'Malley. I think those appointments are statements in themselves in that governors from different parties could both conclude that Reverend Conway had served and would continue to serve the state with distinction. We all know that Reverend Conway is a principled man. He can also be blunt and frank if the question calls for direct response. He can also give and is not afraid to give an applicant a bit of a sermon if it was warranted. It is always useful to have a commissioner who knows how to use the pulpit. And most deliberately, we will honor the careful, thoughtful deliberation that Commissioner Conway offered on all issues, with the principles of always being concerned about how it is affecting the citizens of Maryland and a specific focus on the needs of underserved populations. Throughout his service, Reverend Conway exemplified the impartial and unbiased commissioner whose first devotion is to the best interests of Maryland residents. I could not also conclude today without recognizing the contribution of Mrs. Mabel Conway, Reverend Conway's spouse, who has been with us for virtually every meeting since his first appointment. Thank you, Commissioner and Mrs. Conway.
Now, Ben asked me if I wanted to say something, and for those who are not acclimated to preachers, you know, you never give a minister a pulpit or opportunity to talk. But I would be remiss if I didn't offer some remarks. First of all, I sincerely want to thank you for this opportunity. This indeed is a time of mixed emotions, and to be appointed by the governor and confirmed by the Senate to serve as a Maryland Health Care Commissioner is an honor and a privilege. I am truly grateful to all who are here at the Maryland Health Care Commission, from the chairman to the receptionist at the front office. And I don't want to minimize the receptionists at the front office. They really make you feel good when you come in. You've given me many wonderful memories that I will always cherish. I leave with wonderful memories of Chairman Tanio for your intellect and your keen insight into issues of importance to healthcare. And to the executive director, Ben, I have such admiration for you, very sincerely. Whenever I ask him or compliment Ben about what he's doing and how much knowledge he has, he very quickly gets me off of that kick and say, listen, there are all of these other people here who make my job possible. And so he always thinks about the rest of the staff and how important you are. Then I can't help but think about how wonderful you are in terms of all of the knowledge and about detail. Now, he did not want me to come here not having some idea about what had transpired. And so he called me, and I know you never have anything to do right. So he called me yesterday to tell me, to brief me in terms of what the governor's decision would probably be. So I truly appreciate that, your knowledge and your attention to details. And as a reviewer, if a commissioner hasn't had a chance to be a reviewer, you are missing something. And I want to express my thanks for the situation that I was assigned to. And I just personally want to thank Sue Ellen and Paul for your help and guidance in getting me through that. Glenn, if you don't know it already, you will. I do. All right. So thank you again. And to my wife, Mabel, who always accompanied me. Now, we didn't always do that. She taught 32 years in the schools in Anne Arundel County, and I was 31 years in the schools in Calvert County, and then a second career, 18 and a half years as a United Methodist pastor. But we promised each other that once we finished work and stopped waving at each other when we would leave the driveway and go separate directions to our work, that we would spend some time together. And I've enjoyed that. And after these meetings, no matter how long they are, we always go someplace and we have our favorite lunch someplace together. And so I appreciate Mabel. And finally, and last but certainly not least, I'm grateful to my Creator God for protection. The highways are not always friendly. And today is an example. I think every slow-moving vehicle was in front of me. But I'm thankful that all of the miles traveled, that it's been safe. And I credit it to a great extent to my Creator who looks after us. So again, thank you for giving me this opportunity. And you'll always be in my thoughts and in my prayers. Thank you very much.
This will also be the last commission meeting for Larry Monroe. After 40 years in state service, Larry will be leaving the commission, but not exactly retiring. He will continue and expand his very successful involvement in youth sports and the Amateur Athletic Union. At the commission, Larry has been the person with the most everyday involvement with the medical care database. He did the initial draft of the MCDB regulations and is in regular contact with the payer representatives. Larry is the reason that when Ben appears before the AELR committee regarding the regulations, he's able to say that commission staff knew the insurance company representatives by first name. Larry had hoped to slip out silently out the side door, but I wanted us to have the opportunity to thank him publicly for his dedicated service to the commission and to the state of Maryland. To update of activities. Commissioners, you have received the written updates from centers. Ben, do you or any center directors have anything you'd like to add?
I don't, but I believe we have updates from several centers.
So good afternoon, Mr. Chairman, members of the Commission. I have a couple of additions to the update. On May 22nd, CMS Center for Medicare and Medicaid Innovations released a cooperative agreement funding announcement for the second round of awards for the State Innovation Model programs referred to as SIM. SIM is based on the premise that state innovation with broad stakeholder input and engagement, including multi-payer models, will accelerate the healthcare delivery system transformation to provide better quality of care at lower cost. SIM provides financial and technical support to states to test the ability of state governments to use their regulatory and policy levers to accelerate healthcare transformation. In February 2014, the Department of Health and Mental Hygiene received a $2.4 million SIM grant to fund the development of the Community Integrated Learning Health System model design. Maryland was one of 25 states to receive a SIM planning grant. With CMS now expects to fund 12 states with approximately $20 to $100 million to implement their model design. The Department of Mental Health and Hygiene is expected to submit an application on no later than July 21st. Staff is collaborating with DHMH on sections of the application pertaining to health information technology and the patient-centered medical home. Staff plans to provide the Commission with an overview of the application once it's finalized later this summer. In addition, at the May 15th Commission meeting, staff provided a demonstration of an online advanced directive registry developed by AdVault and integrated into the state-designated HIE's query portal. The registry allows the consumers to create and maintain their advanced directive through a secure website, where healthcare providers participating with CRIS can access the information to inform providers of patient treatment preferences at the time and place of care delivery. At the conclusion of the demonstration, Commissioner McLean asked if the information available at the website had been reviewed by the Attorney General's office. In December of 2013, AdVault had talked to Paul Ballard, Counsel for Health Policy Decision at the Attorney General office, to discuss compliance with Maryland law. Staff is working with AdVault to ensure that more recent recommendations from the AAG have been implemented. A launch date is anticipated for AdVault with the HIE in July. Commissioners, this concludes my update concludes my addition to the update. Sorry.
We'll fix the AB.
Thank you.
Any questions?
Thank you for the update. The information about the online advanced directives registry is exciting. Who or what? How will the awareness of this registry be promoted? Who's going to lead that, or what's the plan for that?
Great question. Thank you for that, Commissioner Stollenwerk. We have much work to do to bolster the communication to consumers. The early effort starts with reaching to providers, the Hospital Association, the Medical Society, the Allied Healthcare Providers, the Nurse Practitioner Associations, providing them with information around the availability of these programs. We're looking for them to help us with that first-line dissemination, and then we're working with the vendor themselves on putting together a more formidable approach or strategy to reach the consumers at large.
Good question.
Thank you, Chairman.
Additional updates?
Good afternoon, Mr. Chairman, Commissioners. At the April Commission meeting, we made a presentation to you about the Hospital Palliative Care Pilot Project. At that time, you approved the data collection and the selection of hospitals. During the past month, the staff have had meetings with each hospital to finalize the agreements with the clinical and coding staff on how to flag palliative care patients in the HSCRC discharge database for data collection that will start July 1st. Greater Baltimore Medical Center was one of the 10 participating pilot hospitals we reported at the April meeting. During our meetings with hospital staff to start the data collection, we realized that Gilchrist Hospice, which manages the palliative care program at GBMC, also manages the palliative care program at Howard County General Hospital, and intended in its application that both hospital programs be included. The program at Howard County General also meets the volume and other threshold criteria that we established for pilot hospitals, and the hospital has agreed to participate in and is able to submit data collection beginning July 1st. Therefore, Commission staff believes that Howard County General Hospital should be added to the list of pilot hospital programs for the study, bringing the total number to 10 hospitals. We just wanted to update you on this development and answer any questions about the project.
Thank you. Any questions?
Mr. Chairman, Commissioners, we're in the process right now, as you know, of finalizing a much more robust and updated hospital website. We have a long-term care guide that has been in existence for several years, and it has a significant amount of information, especially on nursing homes, but much less information from a quality performance standpoint on things like assisted living, home health, hospice. So one of the functions of staff in our center is to follow developments in quality measurement and development and public reporting advancements at both the local and national level. And what I'm going to just share with you today briefly is that there now is an update related to national developments in hospice quality measures. The ACA, Section 3004, which is page 252 of 906, if you happen to read it, laid out the groundwork for collecting data for hospice. And in the way it was structured, starting in 2014, each subsequent fiscal year, hospice programs will have to submit to the Secretary data on quality measurements as specified, and failure to submit is going to result potentially in a 2% point reduction or 2 percentage point reduction in the market basket percentage increase for that fiscal year. So what is in essence happening here is that the ACA requires that the measures that are put forth have got to be endorsed nationally, but it also gives the out that says they can use measures not already endorsed as deemed appropriate by the Secretary. So it further requires the Secretary to establish procedures for making data available to the public. To date, there's no starting point for public reporting, but they are implementing a standardized database called the Hospice Item Set, HIS, and it's the first step to public reporting. The required HIS data collection begins July 1 this year. The HIS consists of electronically completed submitted admission and discharge records, one for each, the admission and another record for the discharge. The data elements are to be used to calculate several quality measures, and those measures are treatment preferences, beliefs, values addressed, pain screening, pain assessment, dyspnea screening and treatment, and patients treated with opiates given a bowel regimen. The regulatory language represents pay for reporting, meaning the act of submitting data measures determines compliance. Performance level is not a consideration when determining the hospice market basket update. CMS has stated we seek to achieve a comprehensive set of quality measures to be available for widespread use in quality improvement and also to inform decision making. So the provision of quality care for hospice patients and families is now an utmost, is a very critical focus in CMS. So they're going to use the same process beyond 2015, and they're considering expanding the number of measures as they go forward and they become available. One such expansion is the Family Evaluation of Hospice Care, the FEHC survey, which is required as a dry run in 2015 to provide information about family and patient experience with the care received. HIS implementation will present, however, challenges for some Maryland hospice providers, particularly those that have not established electronic clinical records. For those with clinical record systems, mapping the data elements needed to complete the HIS must be accomplished. However, the time frames for submission are tight, 14 days from admission to submit the admission record and 7 days from discharge to submit the discharge record. Each hospice program will need to establish protocols for implementation of these processes needed to collect data and procedures for data validation. Carol Christmeyer and the Maryland Hospice Network members and staff conferred after the HSCRC waiver briefing that was done this Tuesday in this very room and agreed to meet and develop a hospice quality report for the Maryland Long-Term Care Guide. Quality measures not only support reporting, but are being integrated into the CON protocols as well. I wanted to give you this update because it's basically consistent with some of the things we talked about earlier today. Thank you.
Thanks for the update. Any questions? Definitely good news. Other updates? We'll move to agenda item number 3, which is a certificate of need for Capital Hospice, doing business as Capital Caring. So Capital Hospice sought a certificate of need to establish a 7-bed inpatient hospice unit in Prince George's County. When Hospice of the Chesapeake sought interested party status, Commissioner Glenn Schneider was appointed to serve as the reviewer of the application. Commissioner Schneider granted interested party status to Hospice of the Chesapeake, and on May 13, 2014, released his recommended decision in the review. Because Hospice of the Chesapeake did not take exception to the recommended decision, there will not be an exceptions hearing today, but instead Commissioner Schneider will discuss why he recommended that the Commission grant a CON for the project. I also note that Commissioner McHale has recused himself from consideration of this matter.
Thank you, Mr. Chairman. I wanted to start, before I got into the nuts and bolts of all this, echo what Commissioner Conway said. I wanted to thank the staff, particularly Kevin, Sue Ellen, Paul, and the rest of the CON team that really helped me collect all the information that I needed, helped me with answering my questions about all the sort of thing that we had come up, and helped keep me legal as I was going through this process. So thank you all very much. And yes, Commissioner, I do absolutely understand what you're talking about. All right. Commissioners, you received my recommended decision regarding the application of Capital Hospice, which does business as Capital Caring, to establish a 7-bed inpatient hospice on the 3rd floor of an assisted living facility known as the Residence on Greenbelt in Lanham, Maryland, which is in Prince George's County. I note that while the inpatient unit proposed by Capital Caring is located within an assisted living facility, the hospice unit will have its own elevator as well as its own dedicated entrance. I granted interested party status to Hospice of the Chesapeake. As Chairman Tanio noted, while this review was contested by Hospice of the Chesapeake, it did not file any exceptions to my proposed decision. In March of 2012, the Commission granted Hospice of the Chesapeake a CON to build a 14-bed freestanding inpatient hospice facility in Pasadena, which is located in Anne Arundel County. Hospice of the Chesapeake stated that its approved inpatient facility would be adversely affected by the approval of Capital Caring's application. Hospice of the Chesapeake had projected that approximately 20% of its inpatient hospice patients at the Pasadena facility would come from Prince George's County and 80% from Anne Arundel. I carefully considered the concerns expressed by Hospice of the Chesapeake, and I note that Prince George's County is one of 2 Maryland jurisdictions that has a very low use rate of general hospice services. I believe that with outreach and education by existing providers in the county, use rates of general hospice services should increase, and with that, use of inpatient services should also increase. Essential to my decision, however, is that there are no existing dedicated inpatient hospice units at all located in Prince George's County at this point. I also want to point out that both Hospice of the Chesapeake and Capital Caring projected that their inpatient hospice facilities would be used by patients of their general hospices already, who are already receiving care in the community. Neither hospice relied on a shift in market share to attract patients for their proposed inpatient facilities, and so I concluded that Capital Caring's 7-bed inpatient hospice facility will not have an undue negative impact on existing providers. For the reasons I outlined in my proposed decision and have partially summarized here today, I believe that Capital Caring's project is needed and should be approved. I move further that the Commission adopt my recommended decision and issue a CON to Capital Caring to establish a 7-bed inpatient hospice unit in Prince George's County.
Can I get a motion to adopt the recommended decision and approval of certificate of need?
So moved.
A second? All right, let's open up for discussions or comments. Any questions for Commissioner Schneider? And you were succinct.
That's great. Well, let me introduce some folks from Capital Caring who are here today. David Schwind, who is the EVP of Administrative Services and the CFO. Cinda Tipple, who is Vice President of Inpatient Services. And Carolyn Jacobs, who's the counsel.
If there's no other questions or comments, all in favor?
Aye.
Any opposed? Any opposed on the phone? You have your CON.
Aye.
So we'll move to a small group market summary of carrier experience as of December 2013. In about 10 days, we will celebrate the 20th year anniversary of the launch of the Comprehensive Standard Health Benefit Program. In the first several years, the program stabilized the small group market, where previously small employers faced great uncertainty regarding premium increases. A single sick employee could spell a double-digit premium increase or worse, cancellation of the policy. The past 20 years have seen numerous challenges. We've made hard choices, and we've been open to experimentation. And the Commission's commitment to small employers has never waned. We are now on the brink of launching the Shop Exchange, which will present new opportunities for small employers to obtain desirable insurance products. At the same time, we will work to define the Commission's role in this important market. First, we will hear from Janet Ennis, who's Chief of Special Projects, who will present the summary of carrier experience for the year ending 2013 on the CSHBP, which includes enrollment and premium information on Maryland's small group market. Janet?
Thank you. Thank you, Chairman Tanio. Good afternoon, Commissioners. Today I'll show you a very brief presentation on the latest metrics on Maryland's small group market. I kept a few slides in the deck for reference purposes that I'll either breeze through or skip entirely, and I'll just be comparing this year in this year's presentations, year-end 2012 to year-end 2013 data, because as you well know, with the exchanges now available in 2014, the Comprehensive Standard Health Benefit Plan regulations only apply to grandfathered plans. However, we don't believe that any of the carriers participating in this market will actually be offering the grandfathered plans. Instead, just the ACA compliant plans inside and outside the exchange. So what you'll see today is that overall participation by Maryland small businesses continued to decline slowly in 2013, and that's especially so in family coverage, which is a reflection of the higher premiums that they experienced in 2013. Those premiums as a percentage of average wage in the state are rising, with the slow to stagnant growth in wages compared to the rising premiums. There are still the same 5 major carriers that are participating in this market. That's remained relatively stable over the past several years, and there is a little bit of expansion in the market in 2014. For example, the Evergreen Co-op is marketing to small businesses on the exchange in 2014. The Standard Benefit Plan has many of the same provisions that are required under the Affordable Care Act: guaranteed issue, guaranteed renewal, no pre-ex. I also left on this slide the very last bullet, which references the affordability cap that applies in this market, which really doesn't have any relevance anymore. But what I wanted to point out, I left it here because I do reference the cap when we get to the slides on the average premiums in this market. But what I wanted to point out here is that there is there is an affordability measure in the Affordable Care Act as well that'll begin in 2015 and apply to the 50-plus market, whereby an employer could be charged a penalty if an employee's premiums are considered unaffordable, meaning their premiums were exceeded 9.5% of their household income, and then that employee went to the exchange and qualified for a premium subsidy. The standard plan has always been a very rich benefit plan. It includes most of the broad categories of covered services that are required under the ACA for the essential health benefits package. And in fact, it was a small group product that was ultimately selected by the state as the benchmark plan for the essential health benefits. It was a Care First small group HMO open access plan that was selected. The next 3 or 4 slides cover enrollment data. As I mentioned, you can see on this first slide the drop in employer participation in 2013 of about 3.5% to 4%. That drop occurred most significantly under the PPO plans, and you'll see why when we address the average premiums on an upcoming slide. And similar findings when we look here at what the employees are purchasing as coverage for themselves and their employees, with a decline of almost 3% overall, and showing here enrollment mainly concentrated in the HMO products, particularly in the HMO HSA plans, and also what's occurring in 2013, similarly to 2012, more than 1/2 of these individuals are covered in the consumer-directed health plans. One other brief comment, seeing here on this slide and the previous slide, I am showing you that there are 3 other plan options available in this market, but they have very little enrollment or carrier participation. The high deductible HMO non-HSA enrollment there dropped off again in 2013 and is only offered by 2 carriers. The EPO products creeps up in enrollment each year, but still only available by one of the small group carriers. Moving next to enrollment by policy, in 2013, we're seeing that drop in family coverage that I mentioned of more than 4% in 2013. That's after a small increase in 2012 and about a 6% increase in 2011. Very slight increase shown here, employee-only coverage, and the continued drop-off with the employee plus one type policies of almost 4% in 2013. As more and more employers are no longer paying for spousal coverage. And looking at this enrollment metric broken down by the age of the subscriber, this market is now experiencing an increase in the younger population of employees purchasing insurance. As you can see in the youngest age band, that increased by 26% in 2013. And you're also seeing here the drop-off in coverage in the older age bands. And this is the first year where we've seen the shift from the older employees to the younger employees since we started tracking this age demographic and reporting it to you in this market. On the next 2 slides, I've condensed the data on the average premium into 2 tables, and I'm just showing you as of year-end 2013. First showing you on this first table the averages with riders, and I'm also just showing you the most popular products ranked by enrollment. And again, the average is important to keep in mind because what you're seeing here are these are blended premiums across all of the policies sold within each delivery system. So with that in mind, as you look at the rates here in the most popular HMO plans, there were the single-digit premium increases for those products. The PPO non-HSA plan are the highest priced plans for small group, and the PPO HSA saw the highest premium increases, double-digit premium increases in 2012 and 2013, which could probably help explain the shift from that plan into the HMO options, particularly to the HMO HSA plans. And on this second table, similar findings when we look at the 2013 average premiums without riders. Sticking with that base plan without riders, as it relates to the affordability cap that I mentioned on a previous slide, I just wanted to point out here that the commission consciously decided not to make any changes to the standard plan as we approached or exceeded the affordability cap in recent years. So basically, we've just been monitoring take-up and affordability in this market in the past few years. And if we had adopted any significant changes to the standard plan, then there would no longer be any grandfathered plan. So with that said, what this graph is showing you is that relative to 10% of the average wage, which was about $5,400 last year, the base plan without riders.
Average wage, $54,000. Right?
Right, right. 10% of which was $5,400. The average cost per employee last year exceeded that by more than 8%. And as we look at trending over the past 8 years, looking back to the first year shown on this graph, 2006, you can certainly see the significant cost increases relative to wages over that 8-year span. And just one final comment on the average premiums. I just wanted to point out here that the more popular HMO products, more than 2/3 of this population are in fact buying those plans with premiums as opposed to the higher priced PPO plans. And this last slide showing you the latest information we have on the loss ratios. It appears that the individuals who continue to purchase the higher priced PPO products use more services with a loss ratio of about 81%. Overall, across this market, that loss ratio was about 78% in 2013. And although this traditional loss ratio is measured a bit differently than the MLR under the federal rule, I just wanted to note that we don't yet know which carriers, if any, might owe rebates in 2013 if they don't meet that ACA requirement to have at least an 80% MLR in this market. So I'll conclude this afternoon with a few outstanding questions, one of which is what is the role of self-insurance, and will that grow in this market where these employers will bear the risk? And what might the very small employers who have been able to offer group coverage, what will they decide to do? Will they decide to drop that group coverage and send their employees to the individual exchange where they might qualify for a premium tax credit or other cost-sharing subsidies? And what will be the take-up in SHOP? And a final question is, what role will this commission play in the future? As you know, we are currently aligning our all-payer claims database to support MIA's rate review process, but we also think it's important to start the discussion today on what other roles the commission can play in the future, perhaps how we might assist the exchange as they monitor take-up and affordability of insurance for small businesses in the future. So before turning the microphone over to the next agenda item where our colleagues from the exchange will provide you all with an update on SHOP and begin that discussion on future options, I'd be happy to address any questions on this report. And thank you all very much.
Any questions or comments?
I was just wondering, are there any things that we're using now to evaluate the small group market that might be worth carrying over as we go to evaluate the exchange, you know, of this 20 years experience? For example, when we see what the premiums are there, would it be worth looking at that compared as what percentage that is of the average annual wage and monitoring that, or other kinds of things that we might want to continue to look at?
I certainly think that this data that we've had over the years would be good benchmark material.
Yeah, it's a different benefit plan,
right.
And I know that makes it different, and it's not a standard benefit plan as such, although the premium with riders is certainly not standard.
Right, and the and it'll be interesting, and actually we're actually seeing it already with the little bit of partnership data we have on the groups that are still getting the state subsidy until SHOP becomes available in June. What a difference the new rating methodology that is required in 2014 under the ACA with a member level rating where each member has their own rate as opposed to the you know, with the way the rating methodology was in small group for the past 20 years.
I would certainly think that's one thing we want to monitor. The other is the percentage of wage. The other would be the medical loss ratio. I mean, that's going to be calculated differently. It's still something that you want to keep your eye on.
Right.
Yeah, so I think, you know, just one point on the benefit structure. Actually, at least for the first 2 years, the benefits in small group will be consistent with what was offered in small group historically, with the exception of habilitated services will be expanded. But really, what small employers are purchasing in 2014 is almost exactly what they purchased in 2013 when CSHBP was in effect. What differs is a point that Janet raised, which is, I think, significant, is that the rating mechanism, composite rating, which existed historically, changed to individual rating. So you saw some significant fluctuations upward and downward for individuals purchasing through small group in 2014. I think we should maybe let Michelle present, and we can see sort of the direction the exchange is going, and maybe we can have a full discussion at that point on what roles we might play going forward.
Terrific. So Michelle, will you come up?
I had a quick clarifying question about the cap. I assume that a cap means it's capped. And so how is the comprehensive standard benefit package exceeding the cap? So I'm missing something.
So the cap historically meant that if the Commission's estimate of the comprehensive standard benefit plan without riders was above 10% of the average wage, then the Commission would have had to shave benefits from the standard plan. So obviously the cap still has meaning, but the policy lever that we would exercise is no longer there.
So Michelle Everly is the Executive Director of the Maryland Health Insurance Program and a Senior Staff Member of the Health Benefit Exchange, and she will outline the plans for launching the Small Business Options Program, also known as SHOP, for the 2015 enrollment.
Thank you, Mr. Chair and Commissioners. Happy to be here to give you an update. Let me talk a little bit about what's going on with SHOP overall that we're seeing around the country at a high level. I don't have detailed numbers for what the different states are doing, but at a high level. And then talk about the experience we've had with Maryland SHOP since we stood up for June 1st enrollment, and talk then about what we're looking at going forward into 2015. So just a level set for all of us, and I think you're well aware of this, but the SHOP is, as you know, a competitive marketplace for small businesses. The big ticket item in SHOP is the ability to get tax credits to really make that insurance more affordable. Also, the provision of employee choice, low-cost plans, and administrative relief for small employers. 33 states went with the federally facilitated SHOP program, and 17 states are in various processes of doing their own program. For Maryland, well, overall, let me back up a little bit and talk overall. What we've seen across the country is that there's been a slow uptick in the SHOP market, and folks going to the SHOP, getting their coverage through the SHOP programs. Part of that is because there has been technical challenges in different states. The federal program doesn't even anticipate to have an electronic solution until 2016 now. They're continuing to delay it. And so there's been a lot of direct enrollment process. So we feel that that's contributed to some of the delays. In Maryland, as you know, we did not get an electronic solution up and running when we had anticipated. So worked with our carrier partners, and effective April 1st, started a direct enrollment process for plans commencing June 1st. We have received, to date, this is as of yesterday, 101 applications. Of those that we've received, we've approved for eligibility 37 of those employers. 6 of the employers received denial letters for various reasons that they did not qualify. And we have 58 applications in process where we need to get some additional information. What we have seen, and I think this is a critical point, 90% of the applications received are for a group size of 1 to 10. We actually don't have any received over 40 employees. So the bulk of what we're seeing is in that small group market. So this program is working now. It's a manual process because the employers are going direct to the carriers. We're getting the application in at the exchange. We're approving that application and sending out notices. But really, it's business as usual with the carriers. We are looking at this point in time, what the exchange is looking to do is to get the electronic version of a shop or the true shop marketplace up and running. The challenge we're having with the direct enrollment is that it's single carrier choice. So for the employee, there's not multiple carriers to choose from, and each employer is selecting one carrier. The exchange has worked with a company called Audacious Inquiry, who did an analysis of different options and put that before the MHB board last month in terms of what should we do with SHOP. You know, the options are, do we stay with direct enrollment? Do we look at getting an our own electronic version up and working with TPAs in our state to help facilitate that? Do we transfer over to the federal facilitated marketplace? What are the options? And the exchange board at the last board meeting indicated that there was support to go with either one or multiple TPAs in the state to really administer a SHOP program so that we could get some type of an electronic interface up and going for this next open enrollment period. So at this point in time, what I brought you, you have the full presentation that Audacious Inquiry made, and it gives the history and it gives everything. But I'm going to focus in just on the point of where we are now and moving forward and what the next steps are. So there will be coming out, the board will be looking at, the MHB board will be looking at requests for proposal, requests for application options at the next board meeting. What Audacious Inquiry presented is that, again, an option would be status quo, direct enrollment, or go out and look at the broker-assisted employer-employee choice model, have employer-employee portals, and then a fully automated SHOP platform. So this is actually going to get filtered into the RFP that will come out. At this point in time, we're looking at working again through that RFP to get TPAs that can commit to at least facilitating that direct enrollment process through the open enrollment, getting to the portal where the employer could work through that employer portal, and then ultimately the employees could go through the portal in a phased approach. And then ultimately getting to a fully automated SHOP platform where there would be EDI transfers, where it truly would be paperless. We want to go forward in the manual process that we've been doing today. So here's a timeline that we've been looking at. I talked about the May board meeting. That RFP, the requirements have been in process right now. Staff as well as our vendors have been working on pulling that together. That will be going before the board this month. The idea is to get that RFP out, get a TPA or multiple TPAs selected to perform the SHOP, and then by the end of 2016 to have a truly fully automated SHOP. What we have in our discussions learned is that there's a lot of communication that is going to be needed. Small employers don't understand what's available or what can be available, so there will be a lot of outreach efforts to really help communicate to these small employers that there are the tax credits, how to go about getting it, and how to get engaged with the process. Again, I'm not going to go through these all in detail. You have it with you, and just as the more talking of what's in that RFP. So if we just get, again, to those next steps, the RFP requirements have now been developed. We will go before the board, then we'll get the RFP out, get those responses back, and start working on engaging with one or multiple TPAs to stand up an electronic program so we can get out of the direct enrollment model with the carriers. The ultimate goal, again, is to have employer choice, the model of having this choice for multiple carriers for the employee, and doing this all electronically. So with that, I'm happy to answer any questions you might have.
Questions or comments?
So in terms of the direct enrollment approach now, the incentive for actually going through direct enrollment would be to get the tax credit.
Correct, and when we work with the carriers, that is what we have really done. I said, if for the carriers right now in direct enrollment, it's business as usual. If it's someone coming in that does not need a tax credit, they don't have to direct them to the SHOP plan for the tax credit. And then when it comes to the tax credits, again, from the exchange standpoint, we're determining that that carrier is eligible and sending them the proper paperwork that they need to demonstrate they're eligible for those tax credits. But then it really moves over to that small employer and their tax accountant, how they go about at tax time doing the reporting. So in terms of all that, then, when we're talking about possible discussion, the broader question of affordability, once you consider the tax credit in there or without the tax credit and use market as usual, those kinds of issues and looking at how that's moving along. One area where I think we could provide useful information, and we have a lot of experience in that area.
Yeah, I mean, I think that that's absolutely the important point is that the exchange will be monitoring SHOP, but evidence, at least gained through 2014, was that take-up was very, very small, even in states that had fully operational systems, which is but a handful. California, D.C. D.C. actually did better than anyone else, but that's with a asterisk, because most of the SHOP enrollment in D.C. was attributable to the congressional offices that were required to enroll in the exchange as part of the ACA originally. So they have, I believe, about 7,000 enrollees through SHOP, but when you actually factor out the congressional staff, it drops to 1,000. 10,000 in total in California. By comparison, in the individual exchange in California, they enrolled over 1 million. So clearly, SHOP's going to go very slowly. I think the exchange board decision represents a desire to scale the investment relative to the possible gain, and small employers, many of are happy with what they are purchasing now. The opportunity for tax credits may not be a big driver, but I think longer term the sense is that the employee choice option, as it becomes better known, may be attractive. All that said, as you see 350 or so thousand people rolled through small group, most will be continuing to buy products off the exchange for the time being. Those would be ACA products that look a lot like the CSHBP, and therefore I think some of the same affordability challenges are going to remain, even though our direct authority to shape the benefit package will be limited. So I think our monitoring roles are important. We are, in addition to sharing information on health plan quality, working to share claim information through the APCD with the exchange as well. So I think that data exchange will further some of the discussion. But I think the Commission on its own has a responsibility in the context of its broad authority on the healthcare system generally to continue to monitor small group and focus on particularly on quality and the scope of the benefit in the small group. I'm particularly concerned as we move from the composite to individual rating, what that's going to have. We do have some indication that at least one carrier is considering going back to composite rating. I don't know if Commissioner Flagg has any comments that he could offer, or Commissioner Khan on the phone, but clearly the biggest disruption in small group was the change in the rating rules. that occurred at the beginning of January 2014. Nothing to do with what the exchange was doing, but actually under what was required by the federal government, and that generated some dramatic premium spikes for some individuals.
Well, I think even going with the, go ahead, Kenny.
Sorry. This is Commissioner Conley. Just to echo what Ben said, what ACA did was because of member level rating, basically under the old PACA rating rules, the rates were actually based on subscribers. So if I have one employee, but I have a family of 3, you would actually just pay that one rate. But now if I have an employee that has 7 members in the family or 3 members in the family, you used to pay the same rate, but if you have a larger family, because everything is now member level based, you pay a much higher rate as a result. So this has caused some, premium rate volatility for some small groups.
I think the other thing carriers will have to look at, even though it's composite, you can do composite rating next year, your composite still has to equal what it would be under member level rating. So it's not going back to the old just average age, here's everybody's rate. There's still, you have to figure out what it's going to equal to make sure your composite rate equals that, and then everybody pays the same thing, but it's not going to just be an easy calculation to do.
Correct.
Other questions or comments? Diane?
So there are so many different moving pieces here, and I am assuming that the policy goal ultimately is to ensure that we've got everybody reduce the number of people who are uninsured. Is there a policy goal related to where people get their insurance? In other words, SHOP versus other small group options versus individual. And I realize I may be overstepping my bounds by asking the question, but is there a policy goal in that regard? And if so, perhaps watching the movement among and across different avenues for insurance may be something of interest to the Commission.
Ben, any comments?
So I think that the Commission has a long-standing commitment to sustaining employer-sponsored insurance. I think that's a long-standing principle that the Commission has, and our work, specifically in small group, demonstrates that. Does the ACA tilt towards the individual market or try to move that off the ground consciously? I don't think consciously, but I think there are probably a few policy, levers or consequences of things that have happened that are tending to push or reduce the incentive to offer employer-sponsored insurance at the very micro level. And I think Janet went into that the availability of subsidies for individuals is going to be continuous, as opposed to the tax credits for employers would only be 2 years. It strikes me as that does discourage some employers from offering that they can point to. Certainly low-wage employees could do better off out of employer-sponsored insurance. But I don't think that there's, as I see it, a conscious effort to diminish employer-sponsored insurance, but the cumulative impact may be something else. I don't know if Commissioner Ronston has some thoughts on that or not.
Actually, I do. I think there is a conscious effort to maintain the employment-based system in the ACA. You've got the shared responsibility for 50 and over, so that alone, and creating the SHOP exchanges is creating a place for small employers to, for lack of a better way of putting it, be a large employer or benefit from the economies of scale. So despite some of the unanticipated consequences that there may be, I think the intent is to have the employment-based system as best we can going forward.
So given that, what's the reason why the question came to my mind is watching the reduction, looking at the charts and the reduction in the number of covered lives, I realized in the comprehensive standard benefit plan. And are they moving? Where are they going? Are they going to SHOP? Are they going to somewhere else? And and maybe we just have the overall measurement of the rate of covered versus uninsured lives in the state. But that's what raised the question to me: is where are we going and where are they going, and do we track that to see are they landing somewhere and still maintain some level of insurance?
Janet, do we do that? Do we do any kind of flow analysis where people are exiting one market where they're coming to?
So we probably do that just through some of the work we do with the CPS in terms of, and over the last decade, as employer-sponsored insurance has declined, public insurance, particularly Medicare, Medicaid has climbed. So there's been that offset. That's a trend that exists not only in Maryland, but of course nationally as well. I mean, I think that's sort of a known process that's happening. Interesting, in Maryland, the percentage of the population insured through employer-sponsored coverage is still quite a bit higher, 4 or 5 percentage points higher than the country overall. So we still have much more employer-sponsored insurance than elsewhere. The decline you see in the small group has been relatively slow, steady deterioration in that market. I think affordability is a major concern more than anything else. The fact is that the incremental changes, employers are less likely to offer attractive family plans than they are perhaps individual plans. So you see the employee getting the benefit, getting coverage, but opting not to cover his family, her family, so on. That it's a little tricky to measure through surveys, but I think we know from the national surveys that that's what's going on. I think we're hoping to do some work with, in collaboration with the exchange and others, on looking at insurance uptake as a result of the rollout of the individual exchange over the last 6 months, to gauge just how much we've lowered the rate of uninsurance in the state. Minnesota released a report just this last couple weeks that showed a rather dramatic. I think they dropped their uninsured rate they estimate from about 8.5% to around 5% as a result of the uptake. And I think it was interesting because that sort of changes the narrative. There was lots of chaos in Minnesota, but despite all those activities, there was significant impact. And I think that's what we should maybe be focusing on and discussing going forward.
Are there comments or questions? Thank you very much.
Thank you.
If there's no other business, I'll entertain a motion to adjourn to the 2 work groups. CO1 will be in this room, and advanced primary care in the adjacent work group. Second? All in favor? Meeting adjourned.